Hello and thank you very much for staying with us right here on The Nation Bernama TV. My name is Jared Rudnam, and today, post-budget, we talk about important things that are happening within the nation, growth, expansion in many different ways. One of the sectors that is so important to us is the health sector. We saw that during the great lockdown, and it's getting more important as we move forward into the future of Malaysia. Now, joining me in the studio is no stranger to the Health Ministry, Dr. DZULKEFLY AHMAD, the Minister of Health of Malaysia, who joins me post-budget to talk about a very important initiative. It's called the Rakan KKM initiative. I know what you're thinking about. A lot of us are thinking about what's going to happen. What are these changes all about? Will it incur more costs on us, the rakyat? Well, we'll find out more about that. Dato Sri, thank you very much for taking time off. It's good
thank you for having me. Truly,
well,
I truly appreciate this. Yeah,
I know I've been following your progress ever since you took over the ministry and when you were there the first time around. And the thing that stands out to me was the first time around you talked a lot about primary healthcare, how important primary healthcare is, and a lot of people didn't see that. But today we understand how much work primary healthcare has to do with regards to, let's say, after the lockdown, psychologically, if a primary healthcare practitioner needs to look after someone, it's easier to get there first. And today you've brought something new to us. But before we talk about Rakan KKM, let's talk about your past 10 months in the ministry and what's it been like.
Right. Thank you again, Gerard. I mean, this is truly an opportunity for me to get to, expound and communicate in this conversation what I intend to do. Right. Reform is the buzzword, and coming 1 year later than others, I thought I was in a way handicapped. But I was there earlier in my first term in 2018 for 22 months. In a sense, this time around, the learning curve isn't as steep though, because I've almost laid down the reform that I wanted to do, which in a way was in a back burner of sorts. Two main reforms. And this is all to do with the mounting challenges of healthcare, not just from the issue of facilities, on human resource, but as well, more importantly, because funding or financing of the healthcare seems to be not sustainable in the long run, essentially because we are a predominantly tax-based system where our funding is really essentially on the revenues of tax. And until and unless we get to also diversify sources of income to do more than just more of the same, I think we will be truly not able to get from the consolidated fund more of what we have been, a lot more than what we, as an upper middle income economy, we are spending about 4.5%, 2.3 contributed by the public sector and 2.1 by the private sector. So all in all,
I have to stop you there. What does it mean for the man on the street with these numbers?
These numbers may not be much to them, but what it reflected is what is perceived as underspending in the health sector. But be that as it may, I'm not really complaining, because it's not so much of how much we spend, but how much we have to spend in a way that create the bang for the buck, spending efficiently, and as and when we get to get more funding, we have got to put our priorities right, and of course more funding would be better for us. But seeing revenue is not increasing as much as we would like to, hence I told Prime Minister when I came back the second time, if you cannot allow me the resource I want, please allow me to be resourceful. And this agenda of Rakan MOH is everything about being resourceful, being innovative, being creative in getting to new sources of income, of revenue, of capital that I could spend. not only coming from what has been allocated to me from the OPEX and the development expenditure coming from the consolidated fund or the federal budget. So that's where the agenda for today, because there has been perception and assumption, sometimes it's a bit more presumptive, where people get to hear a bit of what I've said somewhere in Geneva, and they thought that this is privatization, this is private wing.
So word in the grapevine is this. I mean, essentially we're going to have to spend more money, especially those of us who are earning a little bit more. When it comes to healthcare, it's going to be spending, and this is going to have a cascading effect on the those of us who can't afford it.
True. Right. Let me just.
So at least that's what we're hearing.
Yeah.
Is there any truth to this?
Again.
So we are hearing that. Money will have to be spent yet again by the middle class man, and also those who can't afford healthcare.
Right.
Prices are going to go up.
Yeah. True. No to worry about it, of course, because somehow the construct of the healthcare system in Malaysia is essentially a DUI construct of public, essentially funded by taxpayers' money. And that is essentially for the low-income group, or I may say B40, and as well.
And that will not be touched.
That will not. That's got to be maintained. If anything, it's got to be improved by way of allocation. But if you can't get more allocation, the fact that you're faced with a lot of more other new challenges, expectations, and whatever, patient, experience, expectation, blah blah blah. I mean, this is. But the more important thing is, how do I get to increasing sources of funding so that I get to do what I wanted to do, and this is where it is now. If I can just get to explain to you what Rakan MOH is, and what it is not.
Okay.
Right.
Let's start with what it is first.
Right. What it is essentially, I personally want to call it Rakan MOH partnership. That element of partnership is so very important, Gerard. Right? Now, what it is actually an attempt, an initiatives, which you will see is a game changer of sort. All this while, you have, as I said, public facilities being funded by tax money. Right? And I said, I cannot be asking for more and more. Therefore, I've got to now find a new innovative sources,
new revenue streams,
and as well the business model. And that business model is what created and what this creature is all about, called Rakan MOH partnership. It is essentially a partnership where it is a win-win-win for all those.
Right. Firstly, so it's a triple win.
It's a triple win because all those in the program is going to be winning in this partnership. What is it? MOH get to convince, not private money, it is a government-linked investment company.
Right, so not GLCs, but government GLICs.
GLIC, GLIC. GLICs is what it is. So GLIC, namely, I may say, KWSP or the EPF, where after we presented to them, they believe in us, that this is a model, is a creative model, that they're not giving us charity, they're not giving us grants, they're giving an investment that has got to come with it.
So there must be a proposition of some sort to them.
Of course, there must be a value proposition, there must be return on investment. So, the first partner is a GLIC coming with MOH, and of course, the healthcare workers, of course the specialists, the clinicians, the consultant, the nurses, the whole entire team of both medical, surgical, nurses, and all. They are there as our healthcare, the greatest asset of us, our staff, our KKM staff, and as well, right, and as well the last is of course the B40, those that are subscribing to this MOH, or the Rakan MOH facilities, which I would want to call a Rakan MOH Madani premium economy facilities.
Wow. Rakan MOH Madani premium facility. That's
it's a mouthful.
It's a mouthful, but it offers just the same.
Yeah, it offers. In fact, I would call it premium economy, meaning it is something like you make a choice to have. This is not it's not a secret at all. You have in our health facilities class 3, class 2 dan class 1, right? You pay for what you think you want to be served with, like with all the perks, with all the comfort, you want to, whatever. So what we are doing is essentially through this investment of a GLIC that believes in us, that we can now run, based on either the access facilities that we have in any hospital that we have identified. We have already done our homework to see, we assess access capacities there are, whether in terms of instrument like MRI, in terms of things like CT scan, whatever, and as well the operation theaters and what have you. So getting to the partnership where there is an investment coming in. So we are actually, we are actually now extending our facilities to one that we call it this premium economy facilities.
Right. So one gets to choose.
There is a choice. Exactly. There is now those B40 would maintain themselves with the public facilities, though. Now, for those who would want to patronize us to come and get treatment, premium economy treatment, right? They one other thing, they can have a choice of who they want to see in terms of the specialists there are, and then they get a bit more of facilities that are beyond just we call it premium economy, right? Whatever the second class, the third class, whatever that you can imagine. So that comes with it. Now, what we have immediately is a situation whereby if before that in the hospital A or facilities A, there were, say, 100 B40 patients, getting treatment from there. With these facilities up and running, 30% of those who were in facilities A, in the public facilities before, now come and get their treatment in our facilities, in our premium economy facilities. That is 30% of space that you have created in the B40 public the public health facilities.
Right, it's about chopping and changing.
Exactly. Immediately you created more space. Immediately as you created more space, you actually now allow for raising of the floor. You not only widen it, you raise it.
Wait, so the creating of more space raises the level of the floor.
The level of the floor, because they themselves would also be, as I will explain how the raising of the floor is, because they not only, because if I quickly say this, revenue that we have created from our facilities now cross-subsidize our public facilities. That is indeed raising the floor. So both hospital and clinics.
Right. So whichever way we look at it, there'll be a cross-subsidization of sorts, and it'll always benefit the people who are in need of it the most.
Exactly. Yeah. That is the first win. The first win is B40. Now the second win, as I said earlier, the plethora, the myriad of problem that I face, among others, the attrition rate of specialists going to private, as well now nurses going across the causeway or everywhere else. How do I get to retain them? This is why we thought
the talent retention,
talent retention here, and avoiding the drain, the brain drain, the talent drain, whatever. Now with that facilities that we now created, the premium economy facilities for the B40 and those above, upper middle 40 or even others. With that, we generated this revenue. It was this revenue, this revenue that allows us to pay extra to compensate and better remuneration to our specialists. Our just not specialists, the entire level of activities, right up to even we get to do that, right? So we get the specialists paid better, we get the consultant paid better, we get even the MOs, you get the scrub nurses in the OTs, and everyone else, even the management aspect, even the management,
no one's left behind.
No one's left behind in that sense, because we have now the fund to pay them. That is so very important.
Right.
So the first win is B40. The second win is getting to ensure that we retain our specialists.
Right.
We also get to get the specialists to practice in our facilities. 1 day a week. You know the arrangement that they have the right to go to practice in private healthcare. They would now believe that they want to serve with us. Be it, we all more than welcome. Our latest, this is to give you, this latest information. We had a town hall engagement with almost 500 of our heads of directors of hospitals.
So you had an engagement with everyone in the industry.
State directors of health, most of the state directors of hospital, chief of specialties, consultants, specialists, junior specialists, MOs, matrons, nurses, staff, sisters, and what have you, allied health, dental, pharmacists, they were there.
Everyone who needs to be spoken to or ask questions of has already been engaged.
We engaged them, and just to give you, a very humbling experience with us. They were very outspoken. They keep
They didn't hold back.
They don't hold back. No punches held back. So they gave it to us. All the strong reminders of what we should not commit by way of what they saw in private wings that I have not talked to you about.
Right.
Some of these shortcomings of the private wing and full paying patient that we also have in MOH and as well in MOHE. Right. So all that done, then you have a situation, Gerard, that I said to you, this Rakan MOH partnership get to first benefit the B40, then the specialists, and then the facilities and the service itself. So what I would want to wind up immediately is, of course, don't forget that the investor get to have some form of return on investment for what they invested in us. So you have a win for B40, win for the specialists and all others, the nurses.
Win for the investors.
Win for MOH, because we now can raise.
That's 3 wins only.
Yeah, that's 3 wins. And of course, the last is the investors.
So there's 4 wins now.
It's a win all the way.
Yeah.
Now this is why. When we did a pre and post test for those who were engaged with us, you wouldn't believe it. 96% of those in the hall said that we support this, despite being critical over during the discussion and the conversation. They gave it to us. This should not be done. This should not be done for whatever the experience that they wanted it to be the best. Right. So we raised the clinical delivery of patient care. We also raised the B40, raising the floor, and we also raising the ceiling by way of ascertaining we have our best clinicians and specialists are with us still.
Right. Now what I want to get to is what Rakan MOH or KKM is not.
All right. I hope to be very honest in this. I know it may be hurting to some, and especially for those who have been so presumptuous on us, MOH, on me particularly, that saying that I'm going out for privatization, I'm going to compromise healthcare of the public sector.
So the simple question is this privatization? Yes, no? Then you explain.
No.
It's not a privatization.
Not privatization at all. Why? As I told you, that it is not. It is firstly, as I told you, it's not even private money. It is government-linked investment company. That's one. And we are still a very much MOH entity. We are the Rakan MOH partnership entity called Rakan MOH. Yeah. So So that is certainly, and we are also not, and what we are not is also, we are not a private wing, because a private wing, you better be very careful in this, Gerard.
Right,
you got to follow.
You need to differentiate
I've got to, because we are a different creature. We are a different, I would say, a different creature.
It's not privatization. It's not a private wing.
Yeah.
It's
Why is it not?
Yeah.
A private wing assume that you are actually creating a private wing with a full paying patient, being treated there from money that you have taken from the consolidated fund, the taxpayers' money, which was supposed to build your public facilities. You have taken this to build your private wing, and later on pays only, this is what it is for the time being, unless it has been, paying your specialists. That is among those shortcomings of the private wing. Yeah, you may generate income and very well paid specialists, whatever, but as I said earlier, there is no cross-subsidizing back your public facilities. You don't get to pay every level of activities that were all there as a team of healthcare workers, healthcare team, not only just the specialists, but as well the scrub nurses in the OTs and the perfusionists, everyone, right? So it is not a zero-sum game. Would mean you take from the public facilities to actually initiate and start your private wing. So that is where we thought that we wouldn't want to go down that way. So that is the idea of going and taking. That is a zero-sum game. The private wings earning or what I call as the private wings gain is the loss of the public facility.
So if you look at this, I mean, simplistically, the overarching theme here is sustainability.
You are correct. Yeah. You are correct. I begin by saying that I need to diversify my sources of revenue, income, of funds, so that I get to do what? Raise the floor in terms of creating spaces for the B40 in the public spheres, in the public health facilities though. That I managed to do when I get to have revenues that I can cross-subsidize my public facilities, and then raising the ceiling, creating a premium economy healthcare, for those who are willing to pay, just like you're willing to pay, Gerard, for second class treatment in the hospital. Yeah. So in fact, our system is already. If they say that you are creating tier 2 tiers, no, it's already been there. It is a 3 tiers already: first class, second class, third class in our hospital all these years,
right?
For many decades, for the donkey years that we are.
Saying what you've said, and I think we've got a few minutes left. Can retired public healthcare workers participate in this whole Rakan MOH, Rakan KKM?
Yeah, you're correct. You really reminded me of a very important thing. Now, who gets to run this? Who gets to run this? Among others, we are more amenable. We want to get our specialists that have retired, our nurses that have retired, especially MOH retirees. They can come. They are more than welcome to practice in our Rakan MOH facilities, because this would be what they yearn to be with us, so that we, as I said, raise the floor and raise the ceiling.
Right. Raise the floor, raise the ceiling, keep it sustainable.
Keep it sustainable. Right. And not only looking at your consolidated fund. Here I would dare say that I would want to have more money from Prime Minister, who is Minister of Finance, but if he is not giving me as much as I would want to, as I said, for an upper middle income economy, we should be spending 5 to 6% of GDP. But at least for now, I see that I have a kind of sources of income or revenue stream model that, because of this investment by the GLIC, who believe in us, we can not only improve and empower our health facilities, but as well raise it to one that have got clinical, premium clinical outcomes and healthcare.
Right. Dr. Sri, we've got a couple of minutes left, less than 2 minutes. Your message to Malaysia with the announcement of the Prime Minister's tabling of the budget last Friday, your message to Malaysia moving forward.
Right. I've always said that I'm a man in a rush, in the sense that I've got 3 years to undertake my reform. And my first reform is, of course, health finance transformation, which is, among other things, this is the first initiative that I'm coming out with, to make it sustainable, to make it innovative, to deliver better health outcomes and patient care, and as well soon as population health management or the public health management, so that population health management, PHM, so that is one that I've got to go for that, and we need the correct finance funding for that. But of course, coming close to it, together with it is actually my digital health transformation, which is achieving the national EMR, the national electronic medical records, or the lifetime health record, and as well addressing the myriads of human resource problem of facilities as well as human resource. So there is no quick fix to this, Gerard. Much as I would want to have it immediately corrected, but I know it will take some time. We are doing our supply demands, maldistribution, whatever. So all in all, moving forward, already I could see that managing, as I said, transitioning from pandemic of infectious disease to now pandemic of chronic disease, this healthcare system and the healthcare delivery would hopefully be able to enhance health outcome for the entire country, particularly not just for the M40, the T20, but most importantly, the public health care, for the B40, the low income group, so that we tackle, as you can see, I've tackled B40, I've tackled M40, and as well, I did not touch much on the T20, but I would want them to subscribe to the private health insurances, so that they don't spend out of pocket, which is one of the causes of medical inflationary in Malaysia.
Right.
So I thought I've covered quite a
I think we've covered a lot. What I can tell you before we end this, I don't envy your job, and we'd like to thank you for taking time off your really very busy schedule for joining us. Thank you so much, Dato' Sri, and thank you very much for staying with us right here on Bernama TV. This has been The Nation. We just spoke to the Minister of Health of Malaysia, talking to us about Rakan, KKM or Rakan MOH. The difference is the same. There's a lot of information to be gleaned from it. Stay with us right here on Bernama. For long reads, go to bernama.com. I'm Jared Ratnam. Thank you. See you soon. Bye-bye.